staging of radiation side effects is really first times that we are coming together. So don't expect something that's homogeneous and ready. But we have 5 days in front of us, and I hope we will find time to sit together and to continue the discussions that are really important. Thank you, Paul, for organizing, for pushing, and for forcing everybody to be here. It was a big job you have done, and I'm very grateful that you could do it. This session has 8 speakers. There are only 7 in the program. I have to apologize. Third speaker will be Claire Stannard. The question is, radiotherapy in ophthalmic tumors is a very challenging thing. It plays a very important role. The application has to be done in an interdisciplinary way, which is unusual in radiation oncology. So we have to define rules, we have to find our way how to collaborate. There are different modalities available, leading to very different dose distributions. That's one of the main topic of my talk. And on the other side, one center mostly only have one modality. A common language for reporting what's done does not exist. Why is radiotherapy in ophthalmology different from what I call normal radiotherapy? There are very different aspects. One is we have to treat an extremely small volume, which is not what we are doing in, let's say, other parts of radiotherapy. The absolute dosimetry is not only difficult, it's not done. So if I report 130 gray in Essen, this may be 80 gray or 90 gray in Berlin. And this is something we do not have fixed up to now. The treatment volume is always very close to important functional structures. And finally, there are few places in the world really dedicated to treat such kind of disease. And everybody has a different equipment and everybody is doing things differently. The different target volumes are another challenge. You may have a localized tumor in the eye, you have tumors in the retina, in the vitreous, and you all know on the other side you have also a lot of irradiation techniques. In brachytherapy alone, have a look on the image and you see very different approaches for different situations, but also for the same situation, we have different solutions. We have external beam radiotherapy, protons. We have also external beam radiotherapy, photons and electrons. And we can go back, and sometimes I really like this kind of approach, using X-rays to irradiate. But what we do not have are a clear and reliable knowledge of the dose distribution, and especially not on the dose distribution in an individual patient. And we do not know what kind of dose is applied to the structures at risk in this patient. This was the first publication trying to do this for ruthenium plaques and to come up with some dose volume histograms. And we have to establish such kind of things, and not only in a model, but really for the patient in an accurate way. It can be done, it's a lot of work, but at least we have offered solutions. Then if you look on complete different dose distributions, there's a dose distribution from proton therapy for conjunctival melanoma I'm using to irradiate only at a depth of 2 millimeters. It's very different to what we have seen here, where you irradiate something in the eye. And let's now go also to some different plaques. You see here a tumor 8 millimeter, and I prescribed a dose 100 gray to the apex. I'm using a ruthenium plaques. I have to give 2,200 gray to the here, and I will apply only 1 gray on the other side. I do the same thing with iodine. 100 gray here, 440 gray there, and here we have 15 gray. Another plaque, mixing both iodine and ruthenium. And then you have a very high, you have still your 100 gray here. You have now a reasonable dose here, 1,200 gray, which is tolerable. and you only have 9 gray here. You have reduced the dose to the volume. You have increased the dose to the tumor as compared to an iodine plaque. If you look on something else, now protons, then you realize you are irradiating something which is outside of the eye. And if you look for the future, these are new designs for highly precise plaques where we can reach such kind of dose distributions. But the question is, how do we call this dose what we are applying? And how do we report the distribution? Because side effects will not only be depending from the dose to the tumor, they are depending to the dose you are giving to a volume or to a given structure. So, for example, ruthenium, you have local complications, which means an incomplete destruction of the tumor, which is one of the worst complications if you cannot treat the tumor correctly, or a scleral necrosis. On the other side, you may have systemic complications, systemic in the eye, from iodine because the volume that's irradiated is much larger. And if you look to protons, then you see something out of the eye, even if the effect on the tumor is always the same. Let me also say something on protons. Protons are not equal to protons. So if you use a dedicated proton beam only for eye tumors, you may have a distant fall off from 90 to 10% in less than 1 millimeter. If you have a degraded beam, which is what's actually available in most places, then you go up to 3 or even 4 millimeters. And you are always reporting protons. But this is not the same thing, and in reality, we are comparing apples with oranges. I have to be very grateful to my colleagues from Curie, and I'm now comparing Nice and Curie. It's one of my patients. The Nice machine was failing, and I could continue the treatment here. Very grateful. But if you see, it's the same target volume, different beams, and we are irradiating a much larger volume with this beam as compared to this beam. So this is not a critics. These are the technologies that are available for us. And of course, it would be nice if everybody would have the big Rolls-Royce, but if you have to make your farm, it may be not the adequate car. So how can we select the optimal radiation technique? What is the best solution for an individual patient? And this question we cannot answer with the data that are available up to now. I have some suggestions. Don't look on details. I am only looking on physical aspects and dose distribution. And Norbert always tells me, stop with dose distribution, show me results. He's right, but that's what we have. On the other side, there is some published data coming from retinoblastoma, one from our group and one from Shields. And it's nice to see that both retrospective things have a very similar cohort of patients. The results are different, and they can be explained by different volumes that have been irradiated. So you have a higher risk of radiation retinopathy if you irradiate a larger volume in the eye. If you can reduce this volume, and if it is adequate to the tumor, you can increase the dose to the tumor, and you may also increase the success. But if we try to look on the literature, then we can see that all authors report excellent tumor control and more or less good functional outcome. But we need to report also the side effects. And side effects that are damaging normal structures are very often not mentioned or, let's say, not really highlighted. So we need a standardized reporting system of side effects after ophthalmic radiotherapy. And I hope that for the next 5 days, we will have the time to sit together and to discuss what's now being produced and shown by all these colleagues. And let's go to the next talk in this second day. It's Dr. Westerkemper from Essen, who will tell us something on lids, conjunctiva, and cornea. Thank you.
Good morning. I will talk about the ocular surface, and I will focus on the complications we see after surface radiation. That is mainly conjunctival melanoma, but also carcinomas of the conjunctiva. I think the main point, if we want to find a staging system for different groups and for different studies, is to standardize the description of the clinical findings. And I would like to go through the different tissues on the ocular surface. And if we look on the lids, we often have inflammation early after radiation, but this decreases within the first 6 months. What is a common problem on the eyelids and a chronic problem is the atrophy and the scarring of the meibomian glands, which leads to instability of the tear film and an increased evaporation of the tear liquid. So we have dry eye symptoms and we have chronic atrophy and scarring. We also, if the radiation field is large and includes the lacrimal gland, we have fluid deficiency in the tear film, and we can test that by Schirmer testing and fluorescein clearance tests. So we have to find a way to standardize the testing in different studies. The meibomian gland dysfunction can be kept very simple. So example, you describe the atrophy in a mild, moderate, and severe atrophy. And we very commonly use the Schirmer testing for the function of the lacrimal gland. And if we have severe complications with lid malpositions, we can describe them as present or absent in a simple staging. If you go to the conjunctiva, we have the goblet cell atrophy, which also affects the tear film. And we can show that in the impression cytology, which is a histology of the conjunctival epithelium. You can show the goblet cell reduction and also the squamous metaplasia of the epithelial cells. And you can have a clinical test by the tear film breakup time to show the stability of the tear film again. The goblet cell atrophy results in a mucin deficiency in the tear film, and again in the reduced tear film stability and in increased dry eye symptoms. The conjunctival scarring is a problem not only of the proton radiotherapy, but also more localized after plaque radiotherapy. And it can result in symblepharon and secondary malposition of the lid. So what can we do for staging on conjunctival complications? It's, for example, giving points to the impression cytology changes, as we have in other conditions as well, as graft versus host disease or chemical ocular burns. We can stage a breakup time for the tear film, and we can also clinically or clinical stage the dry eye symptoms of the patients. If we come to the limbus and the cornea, we have the limbal stem cell deficiency. Also here we can use this impression cytology of the cornea to show that the cornea is invaded by conjunctival tissue, and we can also use vital staining with fluorescein, for example. And this results in corneal panels and vascularization of the cornea, and this also leads to deterioration of the visual acuity. And the problem is that these radiated eyes have a very poor prognosis for visual rehabilitation, because if you have very large fields for radiation, you have no good prognosis for limbal stem cell transplantation or keratoplasty. So the staging for the LSCD, we know from the ocular chemical burn, there's a classification by Dua or Roper-Hall, and we can again keep it simple by describing no stem cell deficiency, partial stem cell deficiency, or complete. So this would be part of the discussion, how detailed we want to progress there. Specific complications of the cornea will also include epithelial defects, that would be corneal ulcers and extreme corneal perforations. We have the fluorescein staining as, again, one part of the tests. So you see that one simple test by fluorescein staining can cover different parts of the staging for the ocular surface. So you can also stage them as just present or not present, or we can decide on describing them more detailed. The question is, what do we want to include besides the clinical findings? Is there any implication for immunological or histopathological changes in the staging of complications on the ocular surface? Do we want to know if immune cells invade the conjunctiva and in which period of time after radiation? And do we want to know maybe the specifications of inflammatory cells? And where can we really start with clinical staging, or what is applicable for most clinical studies? Easily, it's Sicker syndrome and the corneal complications. And we also see this state as the most common after radiation, and especially large field radiation of the ocular surface. The lacrimal and meibomian gland dysfunction is also important in my view, and the scarring and fibrosis of goblet cells is not so easily shown because you have to perform this impression cytology, and we have to find clinical tests that are applicable in the daily clinic. So maybe it's important to add more tests apart from the Schirmer testing to define the outcome of radiation on the ocular surface. For example, this tear film breakup time, impression cytology, also vital staining, and looking more closely to the eyelids. And then it's so important to find a standardization for the clinical description and to simplify the staging modalities, because otherwise I think these tests will again be dropped out of the studies. There has been great effort done in the graft versus host disease consensus program, and they have found a staging system, and in many parts of this immunological disease we find parallels to what we find after radiation on the ocular surface. So it may be worth looking at these other consensus programs and how they have progressed. Thank you very much.
So next speaker is Claire Stennard. Thank you for being here.
Good morning, everybody. Thank you. One of the problems with staging systems is if they're too simple, they don't give you very much information. If they're too complicated, nobody's going to use them. So I think part of the discussion is going to be how we're going to manage these systems. So what I did was to look at what systems were available already. And this is the RTOG EORTC late radiation score for morbidity. And you can see that it's really far too simple. It may be fine for people who are not treating eye diseases, but for most of us, it tries to cover everything, grades 1 to 4, and is not really going to be very useful. Sometime in the 1980s came the Lent-SOMA classifications, Lent being late effects for normal tissues, and SOMA being subjective, objective, management, and analytical, which would include the ancillary investigations. And here it gets much more complicated. I don't expect you to read all this, but it's just to show that at least they've tried to break it down into the various parts of the eye. There is a problem in as much as if you look at grade 4 here, blind, inability to perform daily living activities. Well, fortunately, you've got two eyes. So that grade 4 doesn't necessarily apply, because grade 4 in all the RTOG systems implies that there's a severe limitation in your living standards, and that doesn't actually apply to the eye. So yes, there is a system here. Should we look at this system, and should we see if it's applicable, and can we use it? You'll see here, there's the subjective, there's the objective, and then on the other two slides, you've got the management and the analytical, but I don't expect you to go through that in detail, but merely to throw it out for discussion. If we look at the lacrimal gland, for instance, there is a staging system, and again, it looks at various factors and grades them according to 1, 2, 3, 4. Should we be using this, or should we make modifications to this, or should we do something completely different? When it comes to the orbit, there is a staging system. 1995 it is, according to Gordon. And he looked at it very simply. Grade 1, asymmetrical, undetectable to the casual observer. 2, minimal detective asymmetry. 3, moderate orbital contracture. And 4, profound hyperplasia of the orbital bones. And gives a diagram to illustrate each of those. The first, not observable to the casual person, more observable and slowly getting worse. And we're all used to seeing these pictures. So, so really what I'm throwing out is there are staging systems for all these. Are we going to use these? Are we going to build on these? Are we going to start from scratch and use our own systems? And that's basically all I want to say. Thank you very much.
So next speaker is already coming.
I'd like to thank the organizers for putting this exciting event together, and I must admit that prior to this task I wasn't giving the lens much concern. So being a vitreoretinal surgeon, I solved most of the lens-mediated problems by simple removal. But to put together a staging system for radiated lens problems is a challenging and rather complex job, because many factors are actually influencing the formation of cataract, some of which we can do something about and something that we cannot do something about yet. So there are evidence that radiation actually can cause cataract. From the A-bomb victims in Japan, they looked at all the small children, showing that there are a tendency to formation of a posterior subcapsular cataract and anterior cataract in the periphery. But there's actually no evidence in the literature that a similar pattern is found in the adult patient. But there are evidence in the literature that the more radiation you give the patient, the more increase you have in the cataract formation. And this is despite which kind of radiation you actually use. The more radiation, the more increase of cataract. The problem is that, at least for uveal melanoma patient, you have an age distribution that much look like the patient distribution of patients that normally are cataract extracted. So these are the patients with no other ocular disease in Denmark being operated for cataract, and this is the age distribution for uveal melanoma patients. So which are the cause for the cataract formation? And is the cataract actually causing any visual problems? So basically this shows that a major part of the patient actually have a poor macular function. If you have a uveal melanoma, it's always affecting macula at the start of the disease. And when you treat, all these patients with a poor visual acuity never gain good visual acuity. Whereas the patient with good visual acuity in the beginning, actually 50% have a poor macular function 3 years later due to the treatment of macula. There are staging systems already for staging cataract, and this paper just shows that there's no actual difference between the staging system, but we don't know which staging system is actually beneficial for staging radiation cataract. And does it all give any sense if we can prevent it? Is it possible to plan your dosage so the lens will be spared? we heard about different nucleotides and different plaque designs, but we need some software in order to know how to plan this to avoid radiation of the lens. And this paper just showed that you can actually give medicine that should prevent formation of cataracts. This is a randomized study. But not only the primary treatment is a problem, the increased use of CT scans and PET CT scans actually also produce a problem when we have radiation to the eye. If you have a local scan of the brain, you use much less radiation than compared to a combined CT scan of the thorax and abdomen. So, cataract formation is multifactorial. Can the individual effect be isolated? Can the treatment be optimized? And can system be used in order to differentiate different cataracts? The radiation cataract from the senile cataract, from the medication-mediated cataract. And when do we need to do surgery? Should it be when the patient cannot see, or should it be when the clinician can see? And is radiation really a complicating factor for doing cataract surgery? Thank you.
Thank you very much for respecting time. And I hope that the next speaker will do the same.
Absolutely, yes.
Carlo Moschi, your turn.
Good morning to everybody. Thanks to Wolfgang and thanks to Paul. Few slides, because Wolfgang said me just to reduce the time, for a big problem because you know that is the most important consequence, the most important complication after radiotherapy, the final step perhaps for the patient. So try to stage in this kind of problem, we have to think from where we start. And we know that we have a different treatment. And nowadays we have to think that we have a tailored therapy for the present and for the future of the patient. So when we have to speak about radiation therapy, we have to think what will happen for the patient. It's evidence that we have a radical treatment, mainly enucleation, but not only enucleation. We have to see if we have to take off the tumor or not, or is evidence that radiotherapy that is the main treatment that we do normally for this kind of patient. Wolfgang explained us what's about the possibilities and the different language into the different possibilities. Plaque, iodine, and ruthenium have different possibilities because treat different tumor. My proton beam explained very well what's about a beam that is a device only for the eyes or something else. You have to think that nowadays in Italy we start with an active proton beam that change the situation. So every time is let's go, as Wolfgang say, but different language. So go on. We choose the treatment just to save the eye, and we have different double corner, different situation. And when I have to speak about the patient, because I treat with radiotherapy, I every time think what's about the eye finally. I have to enucleate yes or not. And because glaucoma neovascular is the more case situation to do enucleation, for me is important for the patient for the future. So when we have to have a staging of a neovascular glaucoma, we have to think of the risk factor. Of course, the tumor size is important because we have a big volume of radiotherapy. If the tumor is closer to the mainly to opportunities of macula, the involvement of anterior part of the eye, and mainly the retinal detachment. This is another problem, is delay of the patient when arrives the patient to our center. Is evident there is a big delay and the retinal detachment will improve. Again. So what's about it's a pathogenesis? You can see the pathogenesis, but every time the retinal detachment, the ischemia, and the more radiosensitive of the retinal detached to the beam is the main problem that we have. And on the other time, we have to see if the patient have a diabetes, the type of treatment, the modality, teletherapy, brachytherapy, the volume of the radiotherapy is high, and the retinal detachment. Of course, with photon beam, we have more risk to have neovascular glaucoma because normally we have the possibility to treat bigger tumor than with plaque, mainly for the ruthenium plaque. And of course, we can think what about we can do when we have the neovascular glaucoma. But it's evident that, as we can show, we can see there is a different aspect of neovascular glaucoma. Sometimes the patient arrive in a delay because normally when the general ophthalmologist that follows the patient try to treat before to send the patient with the neovascular glaucoma. A flow chart that you use is an effort try to arrive to a staging of this kind of neovascular glaucoma, like macular damage. We have to have a classification looking for the visual point of view or anatomical point of view, or a mixed, looking for the final event that is the enucleation. So, of course, we have a different situation. We try to prevent the neovascular glaucoma at the beginning of the treatment with the radiotherapy, or after when the neovascular glaucoma is evident. And so you can see a different situation. And finally, we see where we start, where we arrive, where we start with radiotherapy and we arrive to the enucleation. Perhaps we have to do something to arrive to treat a smaller tumor just to have a small volume of radiotherapy, or we have to change the indication in radiotherapy for ocular melanoma. Thank you very much.
The next speaker is Norbert Bornfeld.
Thank you very much, Paul, for giving me the chance to be here. And I would like to give you a short overview on radiation complications of the posterior segment. So these are the topics I would like to address. These include the acute retinal damage after high-dose radiation, chronic radiation retinopathy, macular edema, and radiation-induced optic neuropathy. And I would like to start with the acute reaction of the retina to radiation. And this has to be differentiated from chronic retinopathy. And this is a patient who has a flat choroidal melanoma, which was treated with plaque. And several weeks after radiation, what you see is a massive retinal edema, and radiation is a consequence of radiation. But this is not radiation retinopathy, but this is an acute retinal necrosis because of the high dose delivered to the retina. That has to be differentiated from chronic retinopathy. So chronic radiation retinopathy has been extensively evaluated by Archer, and most of our knowledge is based on the papers by Archer. And what he showed in his experimental work was that radiation retinopathy consists of damage to endothelial cells, to subsequent vascular closure, and to microangiopathy, as shown in the trypsin digestant flat mount shown on the slide. And it ends, or it results in capillary closure and loss of the endothelial cells. This is very clearly to be seen in that fluorescein image of a patient who had brachytherapy of uveal melanoma, and you can see all the stages of radiation retinopathy in this image. This is some capillary closure. These are microaneurysm. These are complete closure of all retinal vessels, and this is choroidal atrophy and occlusion of the choriocapillaris. So when can that happen? Radiation retinopathy may occur as a complication of external beam radiation, of intraocular and intraorbital tumors. It may occur, of course, and it does occur after brachytherapy of intraocular tumors, but it does not only occur as a consequence of radiation of ocular tumors, but it may result as a consequence of radiation of extraocular tumors, like tumors of the nasopharynx or tumors of the cranial base. Radiation retinopathy may occur several years after radiation, and the threshold for radiation retinopathy still is not very clear. A couple of years ago, Paul has tested and published a classification and staging of radiation retinopathy shown on this slide. And it starts with stage 1 retinopathy, which consists of all the changes you have just seen in the fluorescein, including microaneurysms, hemorrhages, cotton wool spots. And if these are extramacular, it's stage 1. If these are macular, it's stage 2. If above to these findings, retinal neovascularization occurs, stage 3. And in stage 4, retinal neovascularization occurs and vitreous hemorrhages. These are some clinical cases. This is a patient who had radiation retinopathy after external beam radiation because of a pineal gland tumor. And these are the fluorescein diagrams showing discrete microaneurysms and discrete capillary closure, not a very advanced stage of radiation retinopathy. This is a patient who had external beam radiation with photons because of a brain tumor. And you see a more advanced stage of radiation retinopathy with extensive capillary closure, extraretinal proliferation, and tractional retinal detachment. Pretty much the same clinical appearance as we see in patients having proliferative diabetic retinopathy. And that's the same patient, the late-stage fluorescein, showing extensive damage, extensive leakage of fluorescein, pretty much again the same as one would see in advanced proliferative diabetic retinopathy. There is a patient who had had radiation retinopathy after radiation treatment because of choroidal metastases. And again, you see the typical clinical symptoms, including hemorrhages, cotton wool spots, retinal edema, whitening of the retina, and this is unfortunately a bit pixelated, but in fluorescein angiogram, see that patient has not only these intraretinal abnormalities, but he has extraretinal proliferation with massive leakage, again, very much the same like in proliferative retinopathy in diabetes. That may end up in a disaster, as shown by my previous speaker. And this shows here a macroscopic pathologic appearance of a patient who had iodine-125 brachytherapy of large melanoma that ended up with extensive damage to the opposite retina and resulted in subsequent secondary glaucoma and dropiosis of the iris and blindness of the eye. So this, of course, is a very severe complication. We feel, and others do, and there have been published some papers, that panretinal photocoagulation, these patients may prevent that these consequences occur which lead to secondary enucleation. That is the same patient after panretinal photocoagulation of a proliferative radiation retinopathy. A couple of years ago, again, a Japanese group and the Shields group have suggested to stage macular edema as a result of radiation according to the staging of diabetic macular edema. This is shown on this slide. And I would like to show you just some clinical cases. This is the patient who has such clinical significant radiation macular edema with hard exudates within a cycle of 500 micrometer around the fovea. And that is a red-free image of the same patient. This is angiogram showing, again, there's vascular damage, vascular occlusion, and in late phase, cystoid edema of the retina and leakage of the damaged capillaries. Again, this is another patient showing you different stages of radiation retinopathy with total vascular occlusion in the choroid and staged from no changes and all the stages, different stages of retinopathy in a patient who has a juxtapapillary or juxtamacular melanoma treated with a plaque. Radiation retinopathy or macular edema may be complicated by choroidal neovascularization, as shown in this patient. This patient has a typical CNV with hard exudate and macular edema, pretty much the same as one would expect in age-related macular degeneration. I would like to end with radiation optic neuropathy. To my knowledge, there is no real staging. Optic neuropathy after radiation-induced optic neuropathy occurs as a result of damage to intra- and peripapillary vessels around the optic nerve head. And again, there may be a long latency appearance. Again, there's no real knowledge of the threshold. And this, of course, would be a real advantage if, by discussion here in this meeting and further meetings, to find out what the real threshold is. This is something sometimes subject of lawsuits, as we all know. And it may occur in up to 50% of patients who had brachytherapy of a posterior pole tumor. This is a patient who had juxtapapillary melanoma in his only eye. So this patient was treated with a relatively low dose of 40 grays, but even that low dose of 40 grays proton treatment resulted in vascular damage and vascular occlusion close to the optic disc and limited radiation-induced optic neuropathy. And this is the last slide showing you the disease progression in patients having such radiation-induced optic neuropathy. That is a patient who has a juxtapapular uveal melanoma that was treated with protons. And it took a year, a bit more year, that the first signs occurred of radiation-induced neuropathy and radiation retinopathy, some cotton wool spots, but that progressed within several months. So once that disease starts, it really may progress dramatically, and it resulted in massive exudation surrounding the optic nerve head. And by the years, that became more and more atrophic, but secondary neovascularization occurred, retinal hemorrhages occurred, vitreous hemorrhages occurred, and that patient had not only several injections of Avastin, but he had, of course, panretinal photocoagulation as shown here, but he had to be even he had even a vitrectomy to remove a massive hemorrhage, and that is now the result. 7 years after treatment, this is more or less a blind eye, but it's safe, but it shows you how many complications can result after radiation of the optic nerve and resulting optic neuropathy. Thank you very much.
There's a question we have now to treat is what kind of doses are tolerated to the eye. And our speaker is Lawrence. Here he is. So please.
Good morning, everyone. It's truly my great pleasure to be here, invited to speak here at the birthplace of radiation oncology, the Curie Institute. I am just overwhelmed to be invited by my good friend and colleague, Dr. Paul Finger. And again, I am a radiation oncologist in New York City. I've been working with Dr. Finger for the last 12 or so years at the New York Eye and Ear Infirmary of Mount Sinai in New York, in the United States. Today, I will be discussing the maximum tolerated doses to ocular structures, hopefully to answer a lot of the questions that you had about our previous speaker about doses to normal structures. So maybe I'm going to be talking about late effects, those occurring months, years, decades after radiation therapy. There are several modulators to the tolerances of normal structures in the eye, including the total dose, fraction size of radiation, the duration of time of the radiation, the dose rate of radiation, the specific organ that's being treated, and the volume of that organ being treated. So two concepts that come up often in talking about maximum tolerated doses. The TD55, this is the dose at which there's a probability of 5% complication within 5 years after radiation treatment. And the TD55, this is the dose at which there's a probability of 50% complication within 5 years after radiation treatment. Now, we couldn't really talk about tolerance of doses without speaking about the late Dr. Philip Rubin from the University of Rochester. He was a pioneer and leader in radiation oncology. He was one of the first to actually describe and publish about the tolerance of normal structures throughout the body. Here we have a table of the tolerance doses of TD55 and the TD55 in single dose fraction radiation and fractionated. It ranged in the more radiosensitive tumors like the lens and the eye to the more radioresistant, normal structures, the eye and the lens, and more radioresistant tumors like muscle, bone, and cartilage. As you can see in the lens, the TD55 in single dose fraction is 2 gray. The TD55 for the lens is 10 gray. Now, when you fractionate radiation, we can actually go to higher doses. Increases to 6 gray for the lens and 12 gray when you fractionate radiation, causing cataracts. And again, Dr. Rubin, again, one of the first in the 80s to describe ocular complications from treating head and neck cancers. Here we have the different complications of the eyelid, lacrimal gland, conjunctiva, and other local structures. And here's the incidence of the complications and the different dose ranges of each of these complications. And here's another similar table of the different complications in the eye, the incidence, and the different dose ranges, as you can see, from 3,400 centigrade to 6,500 centigrade. So Dr. Parsons from the University of Florida did a similar study looking at ocular complications after treating radiation patients to the head and neck area. In his study, one thing that was very interesting, he showed that if you keep the dose per fraction to less than 180 to 190 gray per fraction, there are less long-term complications, the retina and the optic nerve, at doses at 5,000 rads or 5,000 centigrade. Now, in the early 90s, with the new development of faster computers, new linear accelerators, modern imaging, the National Cancer Institute actually gathered a group of radiation oncologists headed by Dr. Imami, and they've developed, as we know in radiation oncology, the Imami tables. Basically looked at all the normal structures throughout the body and the dose tolerance, and specifically looking at partial volume effects of radiation to different structures. Let's look mainly at the ocular structures that were studied. So as you can see here, the optic nerve and chiasm, because it's such a small structure, they only looked at it as a whole structure. Someone discussed this earlier. If you look at the TD55 for the optic nerve and the chiasm, it's 5,000 centigrade. The TD55 for the optic nerve and the chiasm goes up to 65 gray or 6,500 centigrade, causing blindness. With the lens, again, because it's such a small volume, they weren't able to look at partial volume effects on the lens. The TD55 is 10 or 1,000 centigrade. The TD55 is 1,800 centigrade, causing cataracts. And for the retina, the TD55 is 4,500 centigrade. TD55 goes up to 6,500 centigrade, causing blindness. So to update the Imami tables, in 2010, Dr. Marks, another radiation oncologist, another group of radiation oncologists, developed the Quantec tables, which stands for the Quantitative Analysis of Normal Tissue Effects in the Clinic. And this looked at the 3D dose volume outcome data to update and refine the normal tissue and dose volume tolerance guidelines, basically updating those Imami guidelines from 1991. There were about 5 different tables, very, very extensive, looking at the different normal structures and the complications and the incidence. The only problem with these tables, they only looked at one structure in the ocular complications. They only looked at the optic nerve and the chiasm. As you can see here, if you kept the dose less than 55 gray, there was a less than 3% chance of optic neuropathy. Between a dose of 55 gray to 60 gray, a 3 to 7% chance of optic neuropathy. Greater than 60 gray, there's a greater than 7 to 20% chance of optic neuropathy. And with single fraction radiation, like stereotactic radiosurgery, if you keep a dose of less than 12 gray to the optic nerve and optic chiasm, the rate of optic neuropathy is less than 10%. So to supplement the Quantec data, Dr. Jagannathan from Australia and his group basically gather all the most recent published data to look at normal structures, specifically looking at ocular tolerances. So in looking at the eyelids, greater than 50 gray cause these complications. In the conjunctiva, doses greater than 50 and 60 gray cause these complications. If you look at the iris, a relative radio-resistant normal structure with high doses of greater than 70 gray can cause severe iritis, neovascular glaucoma. And here we have a list of the TD55 and the TD55 estimated doses for the lacrimal gland, cornea, lens, retina, and optic nerve. So in conclusion, ocular structures inherently have different maximum dose tolerances to radiation therapy. And this is dependent on the total dose given, the fraction size, the time the radiation is given, the dose rate, and the volume. And ways we minimize these late side effects, we use in radiation oncology, we use the following techniques, and like protons, intensity modulated radiation therapy, volumetric modulated radiation therapy, electron beam radiation, stereotactic radiosurgery, brachytherapy, and 3D conformal radiation therapy. Thank you.
Thank you, Lawrence. And we are coming now to the last speaker in this session, Dr. Dandal de l'Institut Curie.
I would like to thanks Dr. Saweben and Dr. Finger to give me the opportunity to show you as presentation of the specific side effect of after radiotherapy in children. As after all irradiation on normal tissues, child tissues at risk to develop two types of events: the deterministic effect, acute side effect, during the radiation and disappear some weeks after irradiation. The light side effects appear after 3 and 6 months after irradiation, and the stochastic effects as carcinogenesis. And for the acute side effects in ophthalmic areas, we have a few information about comparison between children and adult ocular tissues sensitivity. The acute effects probably depends on the cellularity of the cell tissue repair, which can be different from between children and adults. Children's skin not seems to be more sensitive than adult skin, but for some skin effects, such as moist desquamations, children's skin could be less sensitive than adults. And for hair follicles of children, it seems to be more sensitive than those of adults for the same anatomic locations. For the late acute side effects, the intensive multimodality treatment has led to a remarkable improvement of the prognosis in pediatric cancer patients. Survivors are placed at risk of developing late effects of treatment. Body of children are growing, and the irradiation effects to organ development are function depend of age. Two examples: eyes and vision. During the first 3 to 6 months, the retina is fairly well developed, and by 6 months of age, the age has reached about 2/3 of what will be its adult size. Probably is less radiosensitive period. It, in contrary of the orbit growth, where there are 3 growth spurts, and the more sensitive periods is between 0 and 2 years. Just to illustrate the late ocular side effects, I show you publication on ocular light effects on childhood and adolescent cancer survivals on 14,000 survivors at 5 years after diagnosis of cancer. They have divided the groups in a specific group, taking account of the population characteristic and irradiation characteristics, and recorded events: very dry eyes, double vision, legally blindness, cataract, retina condition, and glaucoma. And they find a third dose from which the risk increased significantly. 5 degrees for very dry eyes, double vision, and legally blindness, and 2 degrees for cataract retina condition. They found a median time from diagnosis to onset of the events. It's different for the different events, and the greatest cumulative incidence at 20 years depend of the tumor irradiated. And for the orbital bone development, it's one of the most late ocular side effects. And orbital irradiation inhibits the normal development of growing orbital bones. The age at treatment has a major influence of the amount of orbital growth retardation. The more retardation is observed when patients received irradiation between 0 to 6 months and inferior to 1 year of age. The inoculation after orbital irradiation had no effect on orbital growth retardation in comparison to irradiated orbit without inoculation. And pediatric anophthalmic sockets have a high incidence of a complication than adult anophthalmic sockets after an orbital irradiation. Another side effects is secondary cancer for young people. And I show you only one these studies on risk of new cancers with one we aim the cumulative incidence of secondary cancer in reasonable population. 100 eyes are analyzed from retinoblastoma from 2 medical centers, New York and Boston. They find for hereditary retinoblastoma a high risk of bone cancer, connectivity and soft tissue cancer, eye and orbit cancer and nasal cavity. And for non-hereditary retinoblastoma, an excess risk of breast cancer. For the non-hereditary retinoblastoma, the risk of secondary cancers was low. And for the hereditary retinoblastoma plus irradiation, we find a high risk of secondary cancer. 76% of the cancer are sarcoma at age inferior to 25 years. Sorry. And the radiation with chemotherapy have the higher risk. Conclusion. For the acute side effects, the irradiation effect on ocular tissues seems to be similar for children and adults, but there's not enough data to do a comparison between these two populations. And for the large side effects, it's the same thing for ocular tissues. And added that some treatment associated with any irradiation can increase or reduce the irradiation toxicities, corticosteroid or chemotherapies. The main risks are for growing tissues such as the orbit, bones or teeth. The irradiation increases the risk of an orbital growth retardation. The effects depend on the dose and the age. And for secondary cancer, the irradiation increases the risk of secondary cancer in children. Chemotherapies and irradiation with irradiation increase the risk of secondary cancers, and the risk of secondary cancer is higher for hereditary RB than for no hereditary RB. High incidence of secondary sarcoma before 25 years of age. Thank you.
Thank you very much, Remy. Time has progressed and we have shown a very, very broad field. And we will now need the remaining time of this week to discuss. So I suggest that the discussion now we reduce on 1 or 2 burning questions. And I hope that everybody who is interested in this topic will come to me during the next days and that we can build up a roadmap how to continue the efforts and how to come really to a classification.